a young 36-year-old male who has cholestatic symptoms, bilirubin around 3.8, alkaline phosphate is elevated, suspicious mass in the pancreatic head region, and we did investigate, biochemical investigation, because he's a young chap. His IgG4 is elevated, abnormally elevated. So it looks like autoimmune pancreatitis leading to cholestatic symptoms. He has severe pruritus, that's one of his complaints, and no cholangitis or fever or anything. So what we're going to do now, we're going to evaluate what's happening in the pancreas. So I want to highlight certain salient features of role of EUS in pancreas, especially in indeterminate obstructive jaundice, where we don't know what's happening. I can see some bile there, and let us see what we find in his pancreas. So we will now switch over to ultrasound. We always go to the second part of the duodenum. Park your scope there and go to ultrasound. Okay, fine. I'm going to gently withdraw my scope. This is the gallbladder. You are seeing the gallbladder there. And I'm going to gently withdraw the scope. And what do we find here? I'm seeing the, there's some sludge in the bile duct, I think. And I see the bile duct little. So now we will switch over to frequency. I prefer to start at 5 megahertz. I'm doing a 5 megahertz. And this is a linear. We went straight with linear purely because we wanted to try and see if we will need an Eus Fna from the head area. So I'm seeing a hypoechoic pancreas. You can see this is the whole pancreatic head here. And I'm seeing the bile duct also running inside. I'll show you. This is the bile duct which is getting squashed. Look at that. I'll show you what is the bile duct on a cursor. This is the bile duct. This is the CBD getting squashed here in the pancreatic head area. So that is one thing which I've seen, a little bulky pancreatic head, very, very bulky. You can see hypoechoic pancreatic head with slightly prominent bile duct, I think. Let us see. What is this? That's the gallbladder with sludge. You can see gallbladder with sludge here. So part of the bile duct you saw. There is edematous pancreas. You can see pancreatic duct is little prominent here. This is the pancreatic duct. We all know that the pancreatic duct may not be prominent in autoimmune pancreatitis, but then there are cases where we will have prominent CBD and prominent pancreatic duct in a case of autoimmune pancreatitis. So I've seen the head of the pancreas. I saw little bile duct. I saw the pancreatic duct. Let me see the pancreatic body and the tail. Because we are coming close to our live webinar of today, we thought we'll share with you an interesting case, which is a diagnostic dilemma, especially in young patients. And I'm seeing a very hypoechoic pancreas. Look at this hypoechoic pancreas. I hope you can appreciate this is a very, very hypoechoic sausage-shaped pancreas with dilated pancreatic duct. Look at that. With irregular dilated pancreatic duct. Look at that. Now I'll put color Doppler on it to show you that we are dealing with ducts here. So this is the pancreatic duct, tortuous dilated pancreatic duct. So potential argument, are we dealing with autoimmune pancreatitis, or we are dealing with chronic pancreatitis? Now we all know that recurrent acute pancreatitis can lead to chronic pancreatitis. But when your IgG4 is so elevated, I have more reason to believe we are dealing with autoimmune pancreatitis, which are showing some changes which corroborate with chronic pancreatitis here. So now what's the next step? The next step, according to me, he has some cholestatic symptoms, but bilirubin is not so elevated. So what we probably do is, we'll take an FNA from the head area, and FNA-B, we'll take a biopsy. We'll try and get a core biopsy. And we all know that core biopsy is what will diagnose autoimmune pancreatitis on cytology and histopathology, where we see predominant lymphoplasmacytic infiltrate. And sometimes cytology is not good enough. So what we're going to do now, we are going to try and see. I'm seeing some sludge coming out of the ampulla. Look at this, ampulla is bulging. There's a lot of sludge coming out. So this can explain some of his symptoms. Let me see the ampulla. You can see ampulla with this also. Now, according to the Japanese criteria of autoimmune pancreatitis, they also recommend an ampullary biopsy. So what we do sometimes is the patient has severe cholestatic symptoms. We'll do EUS. We do EUS FNAB. We do ERC. Do a biliary sphincterotomy. Put a stent if there are severe cholestatic symptoms. And at the same time, we'll do an ampullary biopsy. So we have ampullary biopsy to give histological diagnosis of lymphoplasmacytic infiltrate, as well as EUS-guided FNA-B and not C. I prefer to use a 22 gauge needle. A lot of people would argue, no, you cannot get histological material, but contrary to most people believe, but we have seen fairly good amount of histological material can be obtained with a 22 gauge. Very rarely we use 19 gauge needle if the lesion is in the body or the tail of pancreas. If I see a bulky pancreatic lesion like an inflammatory mass, we will go after this lesion, especially from stomach, with a 19 gauge needle. 19 gauge needle from the duodenum can be a formidable task, and those who are beginning in their career in EUS-FNA should not use a 19 gauge needle in the duodenum. You will damage the channel of your scope, and you will have serious consequences because of that. So I'm just trying to figure out what is the best kind of option for this patient. We still have some time, so I'm going to discuss about the possibility of what is to be done in this particular patient. So I'm going to go again back to 5 megahertz. Now, very effective choice of frequency is important, and this is what we have learned over the last so many years of experience. And now I'm seeing the pancreas here. Look at this pancreas. The pancreatic head here. I'm still not very happy with the way I want to see the pancreatic head, so I will go again into the duodenum. I'll position myself properly, and then we will evaluate the pancreatic head. So imagine I'm just slipping out into the stomach all the time. So we're going to stay here at the bulb, go to the ultrasound mode, and then start scanning. Yes. You see the gallbladder part, and this is the pancreatic head part. So this is the area I'm going to take an FNA-B with a 22 gauge needle now, 322. Whenever there is a pancreatic head area, I prefer to use a 322 needle. It gives you a good curvature in the duodenum, and I feel that this particular approach is much more suited for difficult situations such as this. I don't think the way the position is, I can use a 19 gauge here, or I would like to use a 19 gauge here, though you can. See, you can do anything if you really push yourself to do it, but it is not in the best interest of the patient as well as the procedure and the safety of the scope. So we'll not do some. See, I have to straighten out so I can't push even 22 gauge needle with a bent scope. So you have to straighten out. So I've lost the lesion or the pancreatic head out of my sight. And now I'm locking the needle assembly, and now I'll try and get the position back. So this is what I'm going to do now. I'm going to try and get the position back here. Yes, I'm still not in the great position because the needle is holding me. It's upward direction, and I would like to get some material which is reasonable for histopathological diagnosis. So now I'm going to advance my inner catheter. The inner catheter has just abutted against that. You can see that. I can see that inner catheter, two parallel lines. You can see the two parallel lines here. And this is the area I want to get into. This is the area, hypoechoic pancreatic head area. I will check with color Doppler signal. Are there any blood vessels in the way? Oh, there is a small vessel there, right in the path of the needle. Oh, ho, ho. So now I've shifted my axis a little bit. And you can see it has gone away from the site. This is fairly okay. I'm just twisting and turning my scope to get out of the axis. Yeah, this is better. But still there is a vessel, so I will not proceed with FNA here. So what I'm going to do, I'm going to try and find a good window. I'm going to try and find a good window to do an FNA. Yes. Okay, I will withdraw the scope a little bit. I'll withdraw. I'm still not able to find a good window. So this is the issue. So people who are trying to start EUS FNA have to be extremely careful, because you can have serious bleeding from the gastroduodenal artery. Okay, this is the area which looks fairly alright, but still there is some signal in there. So what I'll do is I'll try and elevate the needle track and go away from there. Let us see. And there is a vessel there. Huh? It's a tricky one. So we will try and get a proper position. We will reposition ourselves. So especially when you want to diagnose autoimmune pancreatitis, don't be in a hurry. Now this is a good position, I think. This is a good position. I don't see any aggressive vascular activity here. And we can possibly go ahead. Again, there is a little bit of vascular activity right in the needle track. But it is in a different plane. So let me see if we can go safely. I will look at the pulse rate of the patient. And you can see I'm walking in the lesion. Straight in the pancreatic head. I've gone in a little different. The pulse rate is absolutely stable. You can see the needle right in the pancreatic head hypoechoic area. And I don't see any abnormal vascular blush, which tells me that we are absolutely safe in terms of FNA, even though there are some vessels in that area. So endoscopic ultrasound guided FNA with color Doppler has revolutionized the way you approach pancreas. We are going to gently withdraw the needle. I'm going to be extremely careful when I see some vessels there. Very, very gentle withdrawal. Very, very gentle withdrawal. Very gentle. You can see the aspiration happening there. You can see the aspiration of the material happening from the pancreatic head. And that's it. The pulse rate has not changed. So I have immediately come out. Do not jab your needle again in and out in a case like this when you have arteries around, especially the branch of the gastroduodenal artery. So we are going to take some material directly onto the slide and then onto the bulb for cytology as well as histopathology. Yes. So we got some material here. This is pure tissue. Look at that. Please kindly focus this tissue here.